So moving on to the second topic, which is the mechanism of action, uses, and side effects of aspirin and other NSAIDs. Sorry, not other opiates. That's neuropharmacology. So I'm talking about the mechanism of action, uses, and side effects of aspirin and other NSAIDs. So we know NSAIDs are non-steroidal anti-inflammatory drugs, including aspirin. They are among the most widely used medication globally, valued for their analgesic, anti-inflammatory, and antipyretic properties. So I'll be talking about their mechanism of action, therapeutic application, and potential side effects of aspirin and other NSAIDs. So NSAIDs, non-steroidal anti-inflammatory drugs, are a diverse class of drugs that inhibit the cyclooxygenase COX enzymes, reducing the synthesis of prostaglandins, which are mediators of pain, inflammation, and fever. Common NSAIDs include aspirin, that is acetylsalicylic acid, ibuprofen, naproxen, and diclofenac, each varying in potency, selectivity, and clinical application. Aspirin in particular is unique for its irreversible COX-1. We already know that COX is cyclooxygenase 1 inhibition, contributing to its antiplatelet effects used in cardiovascular disease prevention. And NSAIDs are employed in managing acute and chronic conditions such as headaches, arthritis, and postoperative pain. But their use is tempered by side effects like gastrointestinal bleeding and renal impairment. So understanding the balance between efficacy and safety is crucial for optimizing NSAID therapy in diverse patient populations. So the historical context and development of aspirin and NSAIDs. The history of NSAIDs traces back to the use of willow bark containing salicin for pain relief in ancient civilization. In 1897, Felix Hoffmann at Bayer synthesized acetylsalicylic acid, marketed as aspirin, marking a milestone in pharmaceutical development. Aspirin anti-inflammatory and analgesic properties were soon recognized, leading to its widespread use. The discovery of its mechanism, COX inhibition, by John Vane in 1971 earned the Nobel Prize and spurred the development of other NSAIDs such as ibuprofen, which was introduced in 1969, and COX-2 selective inhibitors like celecoxib. Over time, research has expanded NSAID applications, notably aspirin role in cardiovascular prophylaxis, while also highlighting risks like gastrointestinal toxicity, driving innovations in safer formulations. This historical evolution underscores the ongoing need to refine NSAID use through mechanistic insights and clinical research. So moving to the mechanism of action, we already know that NSAIDs, including aspirin, they exert their therapeutic effects primarily by inhibiting the cyclooxygenase COX enzymes, which reduces prostaglandin synthesis. And prostaglandin synthesis is a key mediator of pain, inflammation, and fever. So the first mechanism of action is the biochemical pathway involves. Under biochemical pathway involves, we have the cyclooxygenase inhibition. NSAID targets the COX enzyme, that is COX-1 and COX-2, which catalyze the conversion of arachidonic acid to prostaglandins and prostthrombosins. COX-1 is constitutively expressed in tissues, that is maintaining physiological functions like gastric mucosal protection and platelet aggregation, while COX-2 is inducible, unregulated during inflammation. By inhibiting COX activity, NSAID reduce prostaglandins levels, alleviating pain and inflammation. However, COX-1 inhibition can disrupt protective mechanisms, contributing to side effects like gastrointestinal toxicity. Under the second one, under biochemical pathway, we have the prostaglandin synthesis suppression. As if you are following me, you know that we've been talking about it reduces the prostaglandin synthesis. So the prostaglandins such as PGE2 and PG12 synthesized nociceptors, promote vasodilation and mediate fever via hypothalamic pathways. NSAID induce suppression of prostaglandin synthesis, results in analgesia, anti-inflammatory effects, and antipyretic activities. That means when when NSAID are being taken, it inhibits the cause enzymes, that which the cause enzyme reduces the prostaglandin synthesis, and whereby when they are reducing their prostaglandin synthesis, it will now result to analgesia, anti-inflammatory, and antipyretic activity. For example, PGE2 inhibition in inflamed tissues reduces swelling and pain in conditions like arthritis. The degree of prostaglandin suppression varies among NSAIDs based on their cause selectivity and potency, influencing their therapeutic and adverse effects profiles. Then the second one, we have the specific mechanism of aspirin. We know that aspirin have irreversible COX-1 inhibition. That is, aspirin is unique among NSAIDs due to its irreversible inhibition of COX-1 through acetylation of a serine residue in the enzyme active site, permanently inactivating it. Other NSAIDs, they are reversible, while for aspirin, other NSAID does the action of reversible cause inhibition, while for aspirin, it does the action of irreversible COX-1 inhibition. This effect persists for the lifespan of the affected cell, as new cause enzymes must be synthesized for recovery. In platelets which lack nuclei and cannot produce new COX-1, this leads to prolonged suppression of the thromboxane A2, a prothrombotic mediator, making aspirin effective for cardiovascular prophylactics. Then another mechanism of action of aspirin is the antiplatelet effect. We said aspirin irreversible COX-1 inhibition in platelets reduces the thromboxane A2 production, inhibiting platelet aggregation and thrombus formation. This mechanism underpins its use in preventing myocardial infarction and stroke, particularly at low dose, that is 75 to 100 mg daily, which selectively targets platelet COX-1 while minimizing systemic COX-2 inhibition. The antiplatelet effect lasts for the platelet lifespan at 7 to 10 days, requiring daily dosing to maintain efficacy. Then other mechanism of action for other NSAIDs, we have the COX-1 versus COX-2 selectivity. Unlike NSAIDs, as I said earlier, most NSAIDs, unlike aspirin, most NSAIDs inversely inhibit COX-1 and COX-2 with varying degrees of selectivity. I said aspirin irreversibly inhibits COX-1 enzyme. So for example, we have ibuprofen and naproxen, non-selective, inhibiting both COX-1 and COX-2, leading to effective anti-inflammatory effects but increased gastrointestinal risk due to COX-1 inhibition. Celecoxib, that is COX-2 selective, it is designed to reduce inflammation with less gastrointestinal toxicity by sparing COX-1 mediated gastric protection. Then we have the diclofenac, moderately COX-2 selective but still affects COX-1, balancing efficacy and side effects. So selectivity influences clinical outcome, with COX-2 inhibitors associated with lower gastrointestinal risk but potential cardiovascular concerns due to reduced prostaglandin production. Then we move to the non-cost pathway. We talk about the biochemical pathway. We talk about the COX-1 versus COX-2. Now we are talking about non-cost pathway. Some NSAID exert effects beyond cost inhibition. For instance, high dose of aspirin and ibuprofen inhibits nuclear factor kappa, a transcription factor that regulates pro-inflammatory cytokines like TNF alpha, and this pathway contributes to the anti-inflammatory effects in conditions like rheumatoid arthritis. Additionally, certain NSAIDs modulate leukocyte adhesion or oxidative stress pathway, enhancing their therapeutic profile through this mechanism, though these mechanisms are less well characterized. Then move to the pharmacokinetic and the pharmacodynamics of NSAIDs. One, we have the absorption and metabolism. NSAIDs are generally well absorbed orally, with bioavailability ranging from 80 to 100%, and aspirin is rapidly hydrolyzed to salicylate in the plasma and liver with a half-life of 15 to 20 minutes for aspirin and 2 to 4 hours for salicylate. Other NSAIDs like ibuprofen, ibuprofen half-life is 2 to 4 hours and naproxen half-life is 12 to 17 hours. They undergo hepatic metabolism via cytochrome enzymes and are excreted renally. Cos2 selective inhibitors like celecoxib have longer half-lives, that is 11 hours, allowing once daily dosing. Then we also have their duration of action. Duration of action varies based on the drug's pharmacokinetic and cos inhibition mechanism. We already know that the aspirin have irreversible cos1 inhibition in platelet persists for days, despite its short plasma half-life due to the lack of cos1 resynthesis in platelets. Reversible NSAIDs like ibuprofen have effects tied to plasma concentration, requiring multiple daily doses. The naproxen longer half-life supports twice daily dosing, while celecoxib's extended duration suits once daily regimens. These differences guide dosing schedules to optimize efficacy and minimize side effects. Then we have the therapeutic uses. Other therapeutic uses, we have the analgesic. We already know that NSAIDs are widely utilized for the analgesic, anti-inflammatory, and antipyretic. And in the case of aspirin, it also has the cardiovascular protective effects. So for the therapeutic uses, we have the analgesic application, where we have the pain management in acute and chronic condition. So NSAIDs are the first-line agents for managing mild to moderate pain associated with various conditions. Then we also have, NSAIDs are also highly effective for headaches, including tension type headaches and migraines, with ibuprofen and aspirin showing rapid onset of action. It is also used in musculoskeletal pain and for dysmenorrhea. Then there are inflammatory uses, whereby they are used in rheumatoid arthritis and osteoarthritis. NSAIDs are cornerstone therapies for inflammatory and arthritic conditions such as rheumatoid arthritis and osteoarthritis. So by inhibiting the cos2 mediated prostaglandin production in inflamed joints, NSAIDs reduce pain, swelling, and stiffness, while the non-selective NSAIDs like ibuprofen and cos2 selective inhibitors like celecoxib are commonly prescribed for rheumatoid arthritis and osteoarthritis, improving quality of life. However, cos2 inhibitors are preferred in patients at high risk for gastrointestinal complications. Long-term NSAID use in arthritis requires balancing efficacy with risks such as renal or cardiovascular effects. Then other inflammatory conditions, we have the ankylosing spondylitis. Then another therapeutic effect is the antipyretic effect. It is used for fever reduction in adults and children. So we now move to the cardiovascular application of aspirin, where we have the primary and secondary prevention of myocardial infarction and stroke prevention. Aspirin irreversible inhibition of cos1 in platelets reduces thrombosin A2 production, inhibiting platelet aggregation and thrombus formation, making it a cornerstone for cardiovascular disease. That is for disease prevention. That's for primary. For secondary prevention, low dose aspirin significantly reduce the risk of recurrent myocardial infarction and cardiovascular disease in patients. The other emerging and off-label uses is also used in prevention of cancer, that is the colorectal cancer, and also used in the prevention of Alzheimer's disease. They are still being investigated. Then we have the side effects and their adverse reaction. Their side effects: one, we have gastrointestinal effects. Under gastrointestinal effects, we have the gastritis and peptic ulcer. NSAIDs, especially non-selective ones like ibuprofen and aspirin, inhibit cos1. Reducing prostaglandin synthesis in the gastric mucosa, which normally protects against acid and pepsin damage. So this leads to gastritis, erosions, and peptic ulcer. The symptoms include the epigastric pain, nausea, and dyspepsia. Aspirin, even at low doses, increases ulcer risk due to its irreversible COX-1 inhibition. We also have the gastrointestinal bleeding. It's low doses, it's associated with 2 to 3. Then we also have the renal effect, that is the acute kidney injury, the chronic kidney disease risk. Also the cardiovascular risk. We have the increased risk with non-aspirin Nsaids. In aspirin protective versus their risk profile. Low dose aspirin, that is 75 to 100 mg daily, is cardioprotective, reducing the risk of myocardial infarction and stroke through its antiplatelet effects. However, at higher doses used for analgesia or anti-inflammatory effects, aspirin may contribute to cardiovascular risk similar to other Nsaids, particularly in patients with heart failure due to sodium retention and hypertension. The balance between aspirin benefits and risks must be carefully considered, especially in patients with multiple cardiovascular risk factors. Then we have the hypersensitivity reaction, where we have the aspirin exacerbated respiratory disease. It is a clinical syndrome characterized by asthma, chronic rhinosinusitis, nasal polyps, and acute respiratory symptoms triggered by aspirin or other Nsaids. It results from dysregulated arachidonic acid metabolism, leading to excessive leukotriene production upon COX-1 inhibition. Under the hypersensitivity effects, we also have allergic reaction. Then we also have the pathological effects, where we have the bleeding tendency, the platelet dysfunction. Other side effects, we have the hepatotoxicity. NSAID, particularly diclofenac, can cause hepatotoxicity ranging from erythromatic cancer, means elevation, to rare cases of acute liver failure. The risk is higher with prolonged use or in patients with pre-existing liver disease. Aspirin has a lower hepatotoxicity profile, but high doses can cause mild liver enzyme elevation. Then there's another side effect to the central nervous system effects, where we have the tinnitus, the hearing loss due to salicylate toxicity affecting the cochlear function. And we have the clinical consideration and risk mitigation. The clinical use of NSAIDs, including aspirin, requires careful consideration of patient-specific factors, potential adverse effects, and drug interaction to optimize therapeutic outcomes while minimizing risk. Effective risk mitigation strategies such as the use of protective agents and selective NSAIDs are essential to enhance safety. So this section explores key clinical considerations, including patient selection, strategy to reduce side effects, drug interaction, and the importance of monitoring and patient education, supported by relevant patient selective and contraindications. Appropriate patient selection is critical to ensure the safe use of NSAIDs. Clinicians must assess patient history, comorbidity, and risk factors before prescribing aspirin or other NSAIDs. Key considerations include the high risk group. Patients with a history of peptic ulcer disease, gastrointestinal bleeding, or renal impairment are at high risk, at increased risk for NSAID-related complications. Elderly patients, that is greater than 65 years, are particularly vulnerable due to reduced renal function and higher prevalence of comorbidities. We also have contraindications. NSAIDs are contraindicated in patients with active peptic ulcer, severe renal or hepatic dysfunctions. Then aspirin is also contraindicated in children with viral infection due to the risk of Reyes syndrome. Cardiovascular risk assessment. For aspirin, low dose therapy is recommended for patients with high cardiovascular risk. but its use in primary prevention requires weighing bleeding risks. So we now move to strategies to minimize side effects. One, the use of protein pump inhibitor. Examples are omeprazole, esomeprazole. So this is used to decrease PPIs, decrease gastric acid secretion, protecting the mucosa from erosion and ulcers. We already said that Nsaids leads to um, leads to erosions and ulcers. So PPI, with use of PPI, it will protect the mucosa from erosion and ulcers. So we have the cos2 selective Nsaids, where we have the celecoxib. This was developed to minimize gastrointestinal toxicity by sparing cos1 mediated mucosa protection. We also have the drug interaction. We have interaction with anticoagulants, interaction with antihypertensive, interaction with lithium, interaction with methotrexate. Interaction with anticoagulants, particularly aspirin, increase bleeding risks when combined. Nsaids, particularly aspirin, increase bleeding risks when combined with anticoagulants like warfarin, heparin, or direct oral anticoagulants. While interaction with antihypertensive, Nsaid reduces the efficacy of ACE inhibitors, beta blockers, and diuretic by inhibiting renal prostaglandins, leading to sodium retention and elevated blood pressure. It is also contraindicated. It also has interaction with lithium, that is, reduces the renal clearance of lithium, which increases the risk of toxicity, and it requires close monitoring of lithium levels. It also has interaction with methotrexate. High dose Nsaids can reduce methotrexate clearance, increasing its toxicity, particularly in cancer or rheumatoid arthritis patients. Then we have the monitoring and patient education. We have to monitor. There should be regular assessment of renal function, liver function, and gastrointestinal symptoms. Is recommended, especially in chronic Nsaid users. For aspirin, in cardiovascular prevention, periodic evaluation of bleeding risks and cardiovascular status is advised. Patients with heart or asthma should be monitored for respiratory symptoms during Nsaid imitation. Then we have the patient education. Patients should be informed about their potential side effects such as the gastrointestinal discomfort, tinnitus, or signs of bleeding. They should be advised to take Nsaids with food to reduce gastric irritation and avoid alcohol, which exacerbates gastrointestinal risk. Education about avoiding over-the-counter Nsaid combination is critical to prevent addictive toxicity. Combination like that is using ibuprofen with aspirin. Then we have the challenges and limitations of aspirin. Challenges and limitations of aspirin and other Nsaids. Nsaids, including aspirin, are widely used for their analgesic, anti-inflammatory, and antipyretic properties. However, their use is associated with several challenges and limitations, including the gastrointestinal toxicity, cardiovascular risk, renal impairment, and drug interaction. And other limitations, we have the asthma exacerbation, pregnancy risks. Nsaid use in late pregnancy may cause premature ductus arteriosus closure. Then hepatotoxicity, that is high doses of certain Nsaids, have been linked to liver injury. Asthma exacerbation, that is Nsaid can worsen asthma in susceptible individuals due to increased leukotriene production. We mentioned drug interaction the other time where I talk about the interaction with anticoagulants, interaction with antihypertensives, interaction with then we have the renal impairment where we talk about that is Nsaid reduce renal blood flow by inhibiting prostaglandin mediated vasodilation, which can lead to acute kidney injury, especially in patients with pre-existing renal disease or dehydration. Then long-term Nsaid use may also contribute to chronic kidney disease. In conclusion, Nsaids, that is the non-steroidal anti-inflammatory drugs, including aspirin, are widely used for their analgesic, anti-inflammatory, and antipyretic properties. Their mechanism of action primarily involves the inhibition of cyclooxygenase enzymes, which are responsible for prostaglandin synthesis. Aspirin irreversibly inhibits COS1 and COS2, while most other NSAIDs, that is ibuprofen and crocin, reversibly block COS1 and COS2 enzymes. This inhibition reduces inflammation, pain, and fever, but also leads to gastrointestinal and cardiovascular side effects due to disrupted prostaglandin mediated functions. So the use of NSAIDs include the treatment of mild to moderate pain, inflammatory conditions, and fever reduction. Aspirin is unique among NSAIDs for its antiplatelet effect, making it valuable in cardiovascular disease prevention. However, long-term use of NSAIDs is associated with side effects such as gastric ulcer, renal impairment, and increased cardiovascular risk. Selective COS2 inhibitors, that is celecoxib, were developed to reduce gastrointestinal toxicity but still pose cardiovascular risk. So in summary, while NSAIDs are effective for pain and inflammatory management, their use must be carefully monitored due to potential adverse effects, particularly in high-risk patients. Thank you.
All right, thank you very much. Thank you very much. Any question? So you understood everything she said?
Thank you.
No. Did you understand everything she said? Did you understand everything she said? Because me, I'm going to, if you understand everything she said, then I'll ask you a question now. Let me be sure that you understood everything she said. What's that? What's that?
Okay.
No, you say something now. What are you whispering? Say what you want to say. We're in class. You were saying COS1, COS2. What
Okay, what is the main function of COS1?
Look at this human being. We are in class there. I said, did you understand everything? You said yes. Do you have any question? You said no. Then I turned. You started asking COS1, COS2. What are you doing? Does it make sense? Ask your question.
What is the function of COS1, COS2?
Talk to us.
Already that COS is cyclooxygenase enzyme.
Okay.
So this COS1, COS2 synthesizes prostaglandin. That's their function.
This has a very serious clinical application. So that is where I want you to throw more light on. I want you to throw more light on this issue of why there is this general is common. Anytime you want to buy NSAID, they will ask you, do you have ulcer? So why would we ask that question? Link it to COS1 and COS2.
I should link it to COS1.
Link the answers to COS1 and COS2. I believe you are a professor in this area because you researched extensively before you came here. So talk to us based on that.
The reason why it is being asked is because we know that COS1 and COS2 they synthesizes prostaglandin, which is responsible for the pepsin and some acid secretion. So when NSAID is being used, NSAID inhibits the COS1 and COS2. It inhibits the function. That is, the synthesis of the pepsin and other acids will be inhibited. So for you that you have ulcer, you already have increased acid. Hey God.
See our teacher. see our presenter. See what he's doing to us. Yeah. Please go through your work again. You made a point on that. There was a place you made a point on that, sir. Yes. Before you can understand that, you should first ask yourself what COS1 and COS2, which of them protect the stomach? Which of them has a function that protects the stomach, gastric mucosa? And which of them?
COS1.
Cause what they produce that protect the gastric mucosa? How do they protect the gastric mucosa? Cause one.
The COS1 protects the acid and pepsin damage.
They do what?
They protect the acid and pepsin damage. So when it is being inhibited,
So that means they protect the gastric mucosa now.
yes,
So how do they do it? Through which process do they protect the gastric mucosa? What do they do? How do they protect it? Because you know why, not all. This what is it called? This Nsaids. Some of them specifically some are not specific, or most of them say they are not specific. They inhibit both COS1 and COS2.
yes,
Am I complete? So if they inhibit both COS1 and COS2, wonderful. As they do so, yes, they can help to one of the cyclooxygenase mediate prostaglandin that cause what is it called, inflammation, normal. So, but in the process of inhibiting it now, some of these NSAIDs will not inhibit both of them, because one of the cyclooxygenase mediates what helps to protect the gastric mucosa. Now, when you some of these NSAIDs, when they now inhibit both COS1 and COS2, yes, it's doing the work by preventing inflammation, helping in analgesia, but at the same time, it's also affecting the bringing out what is supposed to protect the gastric mucosa. In that case now, if somebody, it can even lead to, as a side effect now, or adverse effect, GI bleeding. Then someone that already has ulcer, it will become worse. Is that clear?
yes,
Now, this is what you told us now. Now you told us this now. Very very sweet write up, and we enjoyed it. Now talk to us about it. Now, which of these now? I don't want to tell you which one is which now. Which of them now will now cause that GI bleeding?
which of them will cause the GI bleeding?
When it is inhibited.
When it is inhibited, it's the COS1.
COS1.
Yes, it's the COS2 that we COS2.
Okay. Now, you also said something about there are some that you mentioned. You told us here now, because we don't know. You see that it's guiding us. Two of us. You told us here that now that there are some of them that specifically inhibit one of the focus on only one of the cycle or thereby limiting or lessening the gastrointestinal issue. Two of us. So give us examples of those ones again, and what those at least one of the examples of the drug that now inhibits specific cycle that is selective in its inhibition, and which of the cyclooxygenase does it inhibit to avoid, to be able to take care of inflammation, and at the same time avoid
we have aspirin now. It's irreversibly inhibits COS1.
aspirin
Yes.
only.
For COS1 now.
Okay,
Aspirin.
continue. I'm with you.
Then ibuprofen and naproxen, they both inhibit COS1 and COS2,
Okay.
which will now lead to effective anti-inflammatory effects, but increase gastrointestinal risk due to that COS1 that is being inhibited.
Okay.
Then the celecoxib, that is COS2 selective. Now it's just working on COS2. This one was designed to reduce inflammation with less gastrointestinal toxicity by sparing COS1 mediated gastric infection. Then diclofenac, it's moderately COS2 selective, but it also still affects COS1. So we need to know the balancing of
Okay.
each of them.
Tell us now, the one that among all these drugs you mentioned, which of them, at least, even though yes, which of them can you say it is the safest, at least safest, even though it may not be completely safe, but safest among them for avoiding that GI issue?
That's celecoxib.
Why?
Because it is COS2 selective.
So,
And it was designed to reduce, because it has less gastrointestinal toxicity.
so what is the implication of being only COS2?
Because the impression of just being COS2.
Who can help us there? I talk to us. You. Eh?
Reason there is a COS1 inhibition that causes
Gastrointestinal
bleeding and so the celecoxib that will be safest to use to
Okay.
prevent the GI.
Because it does not inhibit COS1.
Yeah.
Is that okay? Who said COS1? You wait too. You block your ear. Are you with us? Are you sure? Please, even if you don't know, even if you need learn anything about this, this one is very important. If any person go, anybody that want to ask you a question, if you say we have done NSAID, maybe you're going for an interview or going to any just somewhere, you say you are have you done NSAID? Have you done NSAID? Yes. That is the first question. Bam, you hear, because it's a common question, and if they ask you such question, you cannot answer it. This one doesn't know anything. That's the conclusion. This one doesn't know anything. Which school did he even attend? Which school said? They're so please go back to that work again. Review that. Even if you don't understand any of that again, please make sure you learn. You know that. Is that clear?
Yes.
Very important. It's not that celecoxib doesn't cause at all, but at least
Less.
when compared others, it's still it has safer. It's still called because it's but not like other one, like this one aspirin that is just aspirin that are focused on that one, boom, and the other one that even that does affect both of them. All those things. So please let us note that, okay? What is wrong with this thing again?
I have not stopped recording.
Okay, I know. Lecture is still going on. No question again. You could not ask any question.
I want to what there are some yes
She want to ask question. How can you leave somebody with it and you're asking me a question?
no, it's not what
No, with here, please. Let's focus on what we have here. So don't waste time. We are asking on what happened here now. You have other times to ask your question, other questions. We are on presentation. Let's not waste our time. Is your question does it concern this presentation?
Aspirin and Nsaids.
and
Does it concern? Ask her the question. That's why she's here.
there are some products that are like that we're
Be asking her.
supposed to.
You're looking at her.
Diclofenac and
Uh-huh.
stop.
So, and what's the reason of combining the two together? And they say,
Okay. He asked. Wait. Hello. Listen. He asked. Why do you combine the diclofenac and misoprostol? In some brands, yeah. That's the question. I answer.
I should answer. Feel they are being combined to reduce the gastrointestinal toxicity.
Why? How? How? You know it. You know it. I'm asking her. Oh yeah. She has answered you now.
I've answered.
So, but I want to know why. Tell me the reason. It's correct too, but why? Why? What does misoprostol do that will help to at least minimize, even though it may not be totally, at least minimize that effect? What does misoprostol do? Feel free, you can check it up. Feel free.
I can check it up.
Do
Okay.
do your thing. We are in class. We are not in exam hall. Is that clear? Feel free. Check it up. Feel free. Tell us.
Misoprostol.
Please increase the volume. Someone is talking now. Wait. Madam, we hope you are listening to it now. Oh yeah.
So we say that misoprostol is a synthetic prostaglandin A1 analog that protects the stomach lining. So it reduces the risk of stomach ulcers and bleeding associated with Nsaids use.
She's bragging now. Someone is asking her. She's bragging. You try, Sha, but do you even try? Okay, you answered it, but you don't. If you don't reason.
Now I said it reduces the gastro.
How? Why? How?
Because diclofenac. Wait. Diclofenac is inhibiting the cost enzyme. That means
That means.
the misoprostol, that inhibition of gastrotoxicity and everything, it protects the pepsin.
How does it protect it? I don't know it now. Tell us. Say it again. Wait.
Because misoprostol is a synthetic prostaglandin A1 analog that protects the stomach lining.
So, misoprostol is a synthetic prostaglandin A1 analog. Remember the type of prostaglandin that is being mediated, action of cyclooxygenase 1 mediates. That is the class of prostaglandin. Are you listening now? You're talking. These are the class of prostaglandin that cyclooxygenase 1. So because of that now, those NSAIDs that will now inhibit cyclooxygenase action, it will make that prostaglandin not to be synthesized, and they will not be there to protect the GI. Is that clear? Now, when they are now formulating the diclofenac, because they know that the diclofenac also has this effect, they will not add misoprostol in it. There are brands in the market. You know them. One is what? Atrotech. Is that clear? By Pfizer, right? Now, and there are other brands, but I think that one is the most popular. True of us. Now, because of that, it will now help to do what? Minimize that what? Effect. Is that clear?
Yes, sir.
If you don't learn anything in today's presentation, please learn this one, because it has a serious clinical implication. This one is what you encounter in practice on daily basis. Of course, he made mention of the effect of NSAID in the kidney. It's a very serious issue. We take NSAID like as if we are taking water in this part of the world. Any small thing, a lot of kidney issues. A lot of kidney issues. But we may not know where it's coming from. So let's minimize how we take or advise patient or counsel patient to take it when it's what necessary, because they feel that they can just go and buy it anyhow. Of course, if somebody is taking misoprostol, you should be careful. The person should not when the person is what pregnant. Hope you know all those things. So all right, thank you very much. Thank you.